Is arriving when we'll be able to do that again, thank goodness. But we'll go with a webinar format for now. And what I said to Kirsty beforehand is if anyone has any questions whilst I go, pop them in the chat. And if Kirsty thinks they're relevant to what I'm talking about at that moment, she'll interrupt me and we'll address it. I can't see the chat, so we'll wait to the end otherwise, and we'll go through all the questions. And you can ask questions face to face as well. So guided bone regeneration, this has been around in implant dentistry for many, many years. And I did an interview for a magazine about 18 months ago before COVID. And basically, one of the questions I was asked is, what's the biggest change I've seen in 31, 32 years of practicing implant dentistry, which is how long I've been doing it. And without doubt, it's what we can do with bone. And I say to patients almost on a daily basis that there was a time many years ago when we couldn't treat your case, but now we can. And why can we? Because we can now create the bone that we need in most cases, to the point where there aren't many cases we cannot treat. So we very rarely say no to a patient. Admittedly, there are cases where it involves quite a lot of treatment to give them that care, but at least we can do it. At least we can offer it to them. So we're going to focus today a little bit on what we do, the indications for guided bone regeneration. And we're going to look in particular at a range of products, which we'll call the OSIX range of products, which is a bit of a game changer really for me. And these are nothing new. The OSIX range of products have been around for many, many years, over 20 years. And I use them right at the beginning. And it's an Israeli company called Datum Dental that developed it. Different implant companies took it into their stable, and no one really managed to market it effectively. And it was a great product, always has been. And I was very excited when recently, and in the last few months, Dentsply Sirona have acquired Datum Dental. Prior to that, for the past few years, they've been selling the products, but now they own the company. So that tells you something about the quality of this range of products and what they can do, that a company like Dentsply Sirona can bring it into their stable. So when we're really, a lot of the cases we're going to look at today, we're going to focus in the aesthetic zone, because that's where it's critical to have ideal bone volume, ideal soft tissue volume. And why is the aesthetic zone so critical? I think someone's got their mic on. Can they mute it, please? Thank you. And the reason is because labial bone plates are thin around anterior teeth. In something like 80% of cases, they're less than 0.8 of a millimeter thick. So even if you manage to remove an intact upper central incisor, for example, keep the bone intact, you are going to have very thin bone, probably too thin for long-term stability of a dental implant. So there are very few cases that we don't augment. There are very few cases that don't need to be augmented in the anterior, in the aesthetic zone. And then you get further loss or damage due to other factors: infection around the tooth, trauma during extraction, perio disease that's already destroyed bone, and then other soft tissue factors like lack of keratinized tissue, muscle pull, free knee, and these sorts of things. And then you have patient factors, and there are numerous, and we'll not go through them all because time doesn't permit us to, but we know them all. And a lot of it's down to the health status of the patient. But down at the bottom there, here, skeletal structure and makeup of the patient. That is a very important one and is often overlooked, because if any of you have cone beam CTs and you take, let's say, a CT of someone's maxilla, if you look in the anterior maxilla, in a high number of cases, you will see that around an intact tooth, apically, the buccopalatal dimension is significantly thinner than, say, in the body of where the tooth root is. And that really tells us if we were to lose that tooth, we would quickly lose the buccal bone, the alveolar bone, and then we'd have a big problem in terms of bone width. And these patients tend to be petite. They have a sort of very thin skeletal makeup. And you're really behind the 8 ball before you start with these patients. So we all know the principles of implant placement. We're not going to talk about that today. We're not going to talk about 3-dimensional implant placement, guided implant placements, getting your implants in the perfect position. As my good friend Paul Fugazotto says, you can only place implants into 2 positions, the perfect position being one and everywhere else. So that is a given, that the implants are going in the perfect position. Following on from that, how do we sort of rebuild bone? Because that's what patients are now coming to say. A lot of my patients now come to see me. I've come to see you because you're the guy that can grow bone. So how do we do it? We're going to look at that tonight. But it all comes down to me to basic principles. We can't move away from those. In guided bone regeneration, I like to really follow the past principles for predictable surgery. And it's pretty basic stuff. Primary closure, which needs to be passive. So you need to learn how to manage your flaps and manage your flaps properly. Angiogenesis is the A, and that's thinking of the biology and how you're going to get the blood supply and cells into the site. Because if you just blindly pack bone material into an area and not think about the biology, there's going to potentially is not going to be a blood supply to it, and it will not work. S, space creation. So you've got to create the space for the bone. And that's also very important. And then finally, the final S is the stability of the wound. You've got to suture well passively, so it's not going to pull open. One of the beautiful things about one of the membranes I'm going to show you is you can afford a dehiscence, but that doesn't mean to say you can be complacent with your surgery. I've got a supply, my very, very last slide will explain that. So bone augmentation, I'm going to run through some of these slides pretty quickly because it's basic stuff. It comes in many forms. We can use particulate bone grafts. We can use block bone grafts. We can graft sockets. We're not socket preserving. It's a terrible expression. We're socket grafting. A socket is a hole. You can't preserve a hole. And bone morphogenic proteins kind of have come and gone. This is where I think we failed in our technology, because for many years in the early 2000s and maybe for 10 years following that, in my travels around the world to various conferences, everybody was talking about were BMPs. Now it's disappeared. They came, they were too expensive, and they've gone. So we kind of have failed as a profession in that respect. But maybe the next big thing is going to be stem cell. But for me, in my sort of getting into my late 50s now, I will not be using stem cells in my practicing career. We won't have them by then. So we are stuck, I'm afraid, with good old bone and growing bone using the tried and tested materials, newer products as well. Up here, block bone grafts from someone who did lots of them, who would do 1 or 2 a week. As of the last 3-4 years, I don't think I've done 1. And the reason for that is I'm not suddenly seeing patients with more bone. I've found a better way of dealing with these. And they are based around particulate bone. So when it comes to particulate bone, we have a number of different products. One, of course, is the patient's own bone, autogenous. Is this the gold standard? We thought it was many years ago. Then we thought it wasn't, because we had products like anorganic bovine bone mineral, aka things like BioOs, and we thought this was our savior. It wasn't. And now really we're back to autogenous bone in some proportion being a gold standard. So most of my grafts will have an element of autogenous bone. Then we have allografts. Allografts are bone biomaterial that are derived from an organism of the same species. In other words, another human. It could be dead or alive. In terms of where that bone comes from, it could be cadaveric bone, or one thing I'm starting to play around with now is CAD-CAM bone blocks, which are derived from the femoral heads of patients who've had having hip implants or hip replacements. They donate the femoral head, and this bone is derived from that after going through a very meticulous treatment process. So your human stuff could be from a human that's still living or a human that's no longer living. Then we have xenografts. Well, the definition of a xenograft is a bone or a product from an organism of a different species. So this could be cow, pig, horse, duck, whatever you choose. The most popular xenograft will, of course, be bovine. And then we have synthetics, and there are a number of synthetics out there on the market. I personally believe that, in my hands anyway, they don't work as well or as predictably, and they certainly do not allow you to tackle the big defects. And really, for the subject of tonight, we're going to look at big defects. I'm not really interested in contour. Well, I am interested, but not in this lecture, of contour augmentation around a few exposed threads of some implants, because many things will work there. You don't need me to tell you about all that. Still on basic principles, we have something called osteoconduction, which is the support of bone growth, which provides a scaffold for cellular activity. And that's very much a passive process. And then we have osteoinduction. Now, osteoinductive materials will attract and allow cells, osteoprogenitor cells, to proliferate and differentiate. And that's also very much a passive process. And then we have osteogenesis, which is basically the formation of bone that requires viable osteoblasts. And that's an active process. And it's the active process that we really should be interested in. So in terms of desirability, we go down that arrow. So from the least to the most, we want osteogenesis. An example of sort of these materials, well, our osteoconductive materials will be our allograft, or mineralized allografts, our xenografts. Bone morphogenic proteins are more osteoinductive. That's recombinant BMP2. And then the only osteogenic material I'm afraid we have at our disposal is autogenous bone. So if I'm saying we need some osteogenesis in our grafts, then that's only going to come from autogenous bone chips or autogenous bone in some form. Well, we've covered that already, so we'll jump on that, jump away from that. But an example of allografts, in the UK, probably the most popular materials are Mineros and Puros. They are mineralized cortical and corticocancellous bone chips, and they provide a scaffold. They are osteoconductive. The cancellous bone increases the surface area for osteogenesis, or for angiogenesis, of course, the establishment of a blood supply. And your xenografts, which can come from different animals, of course. Examples of xenografts are Symbios from Dentsply Sirona, Mineros X from BioHorizons. The market leader, of course, and the one we all know about is BioOS. We've become very focused in this country on BioOS and BioGuide as being pretty much the only go-to materials. And they are great materials, and I use them both a lot. But when you're in the business of regrowing bone, maybe this isn't going to provide you with the best solution. So we go back to our osteogenic material, which is autogenous bone. How are we going to harvest it? I'll put this slide in because it just shows a block that we did many years ago. And we used to pack some autogenous bone around our blocks, and we would basically collect that maybe from a variety of different sources. The flutes of implant drills is a pretty good source. So there's a big sort of sexy comment at the moment, slow drilling protocol. Well, I'm afraid slow drilling protocol is not anything new. I've been slow drilling for many years. Why? Because it allows me to collect autogenous bone, and it's decent quality, to be fair. It's full of cells. So run your drill slow without much irrigation, and you can collect pretty good amounts of autogenous bone. Maybe not enough for a big defect, of course. Then we have bone traps, and you can buy many different types. Some can be disposable, some can be reusable. This was my favorite one. This is, and I still use it from time to time. It's the Astrotech bone trap, funnily enough, but I've been using it since they were owned by Astrotech, which wasn't exactly yesterday now. The problem with bone traps is it doesn't give you particularly good quality bone, because if you think about it, it's attached to your suction, and yes, the bone will go in there, get filtered out, but air continually runs through that suction while you're working away, and that bone tends to dry out. So often you go and retrieve your bone from these bone traps, and especially if you've been running the suction after you've finished aspirating and you've forgotten about it, you'll have a dry dust, which is of absolutely no use whatsoever. So bone traps are good, but of limited use. This is probably the thing I use most of all in most cases I do, and that's very simply a cortical bone scraper, or known as a safe scraper. And if we look at it in this view here, there's a little sharp blade there, circular blade, that will allow you to run that against cortical bone. Bone is collected in this chamber, and it will look like this. And it's really quite efficient, and you get pretty good quality bone. I mean, for example, if I'm doing a sinus graft and I need some autogenous bone, I won't drill away at the buccal bone to create my access window. I'll scrape away with a scraper and collect a fair old bit of bone. If I'm harvesting from a secondary site, like the posterior, like the ramus, the lateral border of the ascending ramus, I'll take some trifine cores, mush them up in my bone mill, but I'll also take a few safe scrapers or cortical scrapers and collect some more that way. These are big defects we're talking about. We need a lot of bone. I'm looking to collect at least 50 to 60% in terms of the proportions I'm going to mix with my biomaterial. And don't be afraid. And it was an obvious thing that was taught to me on a course only last year. I would use one of these safe scrapers, and I'd be going and going. After about 30 seconds, it becomes less efficient. But I go and go and go, and it gets harder and harder. You get sore fingers, until someone said to me, and that was Istvan Urban in Budapest. I saw him using 3 or 4 in one patient. I thought, well, that's blindingly obvious, isn't it? Of course you would. They're not particularly expensive, and you know, as he says, scrape away for about 30 seconds, you get sore fingers, give yourself a 30-second rest, another 20 seconds, and that scraper is done. And if you need more, open another scraper. So don't be afraid to use more than one in a patient. Don't be miserable about it. Then if I need lots of autogenous bone, I'll pretty much go to a secondary site, and I'll use a trifine, and I'll take 2, 3, 4, 5 cores. And I'll put them in something like this called a bone mill, and I'll morselize them to create particulate bone. In fact, I won't do that. My nurse will do that. So I'll collect the cores. I'll pop them onto a sort of collecting dish like that, and my nurse will take them away one by one and morselize them while I'm working away, and then present me with my granular mush, which is effectively what it is. You can use piezo surgery, but it's not very efficient. Why? Because you need a lot of irrigation with piezo surgery, and the bone you collect tends to get washed away quite quickly. There's no accident that these are company photographs from Mectron, because I've never been able to collect anything like that with my piezo surgery unit. So I don't really bother. It's not that efficient. So let's go to sort of the indications of augmentation. I'm running through this deliberately quickly. I want to show you cases. So socket grafts, well, we're going to not really talk about socket grafting tonight. Suffice to say that I've got a study about to be published on socket grafting, which I'll just mention halfway through. Particulate grafts with simultaneous with implant placements. This is day to day in my practice, every single case almost. Then we have contour augmentation, which is basically what I define that is when your implant is in and surrounded by bone, and all you want to do is basically create contour of the tissue. And that you're using a different sort of material, because there maybe something like a xenograft like BioOS is good, or say BioOS collagen or something like that, because you're just using it as a filler. You're not really that desperate for bone to form. You want something pretty much non-resorbable to sit under the tissue in front of the implant and support and create thick tissue. And these xenografts are great for that. We can use it. You can have initial bone grafting. This is now not alongside implant placement. Implant placement will come many months later. You can use blocks. As I've just said, pretty much rule blocks out in my practice. Not seen, apart from the CAD-CAM blocks that we're starting to do, which is a different thing. Initial bone grafting techniques using particulates. This is going to be the focus tonight. And the use of membranes. If you're going to try and do what we're going to do tonight, you need membranes. Which brings us on to membranes. And these can be, of course, from different sources themselves. They can be bovine, porcine, synthetic, natural. They can be resorbable. They can be non-resorbable. They can be cross-linked resorbable. It's very confusing. But to sort of cut through the confusion, you need to understand what we're looking for from membranes. I've thrown this in here because I get this thrown at me all the time. Periosteum is a natural membrane. You don't need to use membranes. Well, to a point it is. But if we're going to manage flaps, and if we're going to use a sufficient volume of material that will not allow the flap to close again without us doing something like releasing the periosteum, which I kind of do with a little bit of scoring incisions, but I don't really do too much of that now. I use blunt instruments to stretch the connective tissue fibers, but you're stretching them beyond the periosteum, then your periosteum cannot really behave as a natural membrane because it's not intact anymore. So periosteum could be a natural membrane, but it's no use to us by the time we're finished with it when we're doing our bone grafting. So resorbable, non-resorbable, not going to dwell on this. If it's resorbable, how long does it last? And native collagen membrane doesn't last very long. Maybe we say six to 8 weeks. But the thing to remember is if it's going to last 6 to 8 weeks before it's resorbed, how long is it performing a barrier function for? Maybe 2 weeks before it's sufficiently broken down to actually not performing its barrier function. But the good thing about resorbable is you don't need to retrieve them. Disadvantage is you can't really maintain space very well. And I use other things for that, as you'll see. There's no synthetic resorbable membrane, by the way. Non-resorbables, well, you do need to remove them. And I still use some titanium reinforced Gore-Tex membranes for the big defects. For the defects where we're trying to grow horizontal and vertical bone, I don't think you can really beat titanium reinforced for that. And of course, they're all synthetic by their very nature. They're Gore-Tex. They're expanded polytetrafluoroethylene, EPTFE. These are the non-resorbable ones. You can use titanium mesh. Haven't used titanium mesh for many years. They're not fun to use. They do dehiss. When they dehiss, it can create a bit of a mess. Funnily enough, you tend not to lose your bone underneath, but they're not pretty. We have better things, I think, now. And the resorbable ones, the native collagen is classically BioGuide. And then you have extracellular matrices. But the one we're going to focus on today is a cross-linked porcine collagen membrane called OSSIX Plus. Examples of membrane where there are dozens and dozens and dozens, but these are just a few of them. It's interesting that this is how they kind of look, but there's only two that has over 100 publications, scientific publications in peer-reviewed journals that support their use. Of course, one of them is BioGuide, but the other one, interestingly enough, is OSSIX Plus. And this goes back to me saying that this OSSIX products are nothing new. The OSSIX membrane has been around for a long, long time. What do we need from our membranes? Well, it has to be biocompatible. It has to exclude cells, the soft tissue cells in particular. It's got to be well tolerated by the host tissues. You need to handle, it needs to be easy to handle. It has to maintain that space ideally and good mechanical and physical properties. This is the ideal membrane. when it comes to collagen membranes, well, it can be non-cross-linked, natural cross-linked, or artificial cross-linked. If they're artificially cross-linked, there's a number of ways of doing it. And the one we're going to focus on is a sugar-coated, they call it Glymatrix technology. I'll show you a little bit about some schematic drawings of the cells in a minute. It's basically ribose sugar. And that seems to be the unique thing about the OSIX products. These are company slides, and this is how they do the cross-linking process in the factory. I would go into it if time permitted, but it's a very intricate process. But what it looks like in clinical situations is this. You can actually see the cross-linking. It's the sort of meshwork that it creates. And there and there. And when you see the results, you'll see what the effects of that are. I think we'll focus a little bit here. It's on the biodegradation, you know, how quickly do they degrade and resorb? Well, BioGuide is the quickest. BioMend is pretty quick also. So these are a matter of several weeks. BioMend Extend, which is a cross-link version, will stick around for longer. Interestingly enough, OSIX is around for several months. And when we re-enter, say after about 4, 5, 6 months in some cases, we'll find there's a fair bit of the membrane still there, which in a way is reassuring. It's performing its barrier function for a longer time. And there's an example. So greater than 24 weeks we're talking about for the OSIX range of products. In terms of soft tissue integration against vascularization, the native collagen and the cross-linked ribose-coated collagen are at opposite ends of the spectrum. So that's why in my biomaterials cupboard, which is not a drawer, it's a big cupboard, I have a range of materials because I will use native collagen on many occasions. I will use cross-linked collagen on other occasions. And it's not to do with which way the wind is blowing outside, it's to do with the clinical situation that's facing us. So it's a confusing area, membranes. There are very important questions we need to ask though. If we're going cross-linking, what's the cross-linking agent or method? And there's a very important reason for this. What's the resorption time against the barrier function time? So if it's going to be resorbing many months afterwards, we're not really interested in that. We're actually interested in how long it's performing its barrier function capability. And as clinicians, that is what we really must focus on, is what's the evidence, where's the science? It's got to be good science. It's not what the local rep is going to bring in and say, you know, I'm going to do a lunch and drop off some new product. You need to look at the science. And that's why I circled the two membranes I effectively use in my office, which is the native collagen, trade name BioGuide, and the cross-linked ribose-coated cross-linked collagen, OSIX plus OSIX Volumax, which we'll come on to. So the OSIX plus OSIX Volumax, OSIX Bone, these are the three products they do. And I'm going to focus a lot on OSIX plus, a little bit on OSIX Volumax, and a small bit on OSIX Bone. But I think OSIX Bone is a very interesting product. And you've got, these are three very different products that you have to, if you're going to embrace this technology, that you probably have to carry all three. Not so much of the OSIX Bone, because you might not use that quite so much. But for example, someone emailed me, a dentist emailed me only last weekend. So I'm very interested in the OSIX products. And I sort of replied to the email by explaining the indications for OSIX Plus and OSIX Volumax. And they came back and said, well, I was really only interested in the OSIX Volumax. And I'm kind of thinking, well, or OSIX Volumax membrane. I said, well, OSIX Volumax is not really a membrane. And the two things are completely different materials. So it depends what you're trying to do. OSIX Plus, well, the best way of demonstrating these is with cases. And listen, that's why we're all here. We want to see some examples. So let's look at this case. Multiple edentulous spaces in the aesthetic zone. Well, if we look at the cross-sectional slices from a CBCT, we can see thin resorbed bone. And where the bone is really resorbed is here. And that's where we want to grow some bone. We could potentially place a narrow implant in there, but think of the angle it's going to go in at. Not at a restorative, any restorative use to us. So we need to regenerate into this sort of buccal concavity. This is how it looks. And you can see quite clearly a large void there on both sides. And we'll classify this as a class 1 ridge deficiency. In other words, the crest of the ridge actually has sufficient width, but it's beyond that where it doesn't. So this is one way I'll create or maintain volume, and I'll use tenting screws. Go through a lot of tenting screws we do. And what these are basically, it's not exactly complicated stuff. We use a series of screws that will support not only the bone, but they will support the membrane as well. And you'll see a few cases later on where our bone regeneration is at its best exactly where we put a screw. So we're using freeze-dried bone allograft. This is corticocancellous bone chips, allograft, human-based. And we'll place that around the tenting screws. And then we take our cross-link collagen, our Ossix Plus membrane. And slides make this stuff look quite easy. I can tell you that the handling of Ossix Plus is not, say, as easy as BioGuide, for example, amongst other things. It's a bit trickier, and there's a bit of a learning curve. And if you're going to, after this lecture, if you're going to say, I'm going to try this stuff, and you go out and buy a few boxes, be patient with it, and I'll give you a few tips along the way. But more importantly, I would say come on one of the workshops we're going to run later on this year and early next year, where we'll actually handle these materials, and I can really properly show you the tips and the tricks to get the best results with it. We will, and as I go along, I'll show you, you'll see how we do it. And then we suture up. Now we wait, in this case, 10 weeks post-op, it's all looking great. We'll leave this stuff, 6 to 8 months. Yeah, I mean, no rush to re-enter. We'll usually take a new CT, and this is typically what we're going to see. A filling out of that buccal concavity. You can see where the tenting screws have kind of done their job. And I think this is 6 months later, I think if we waited another 2 months and took a CT, we would actually see a very much more demarcated cortical layer here. This bone will corticize, and we'll lose that cortical bone as part of the remodeling process. It really is quite impressive. And then we re-enter, and you can see the bone growth up to the top of the tenting screw, because we didn't actually pack bone over the top of the tenting screw. I've done that in the past to my cost, because then I've had to remove that bone to retrieve the tenting screw. So what's the point? What's very interesting is you can see, and what's the best view here? Probably here, you can make out membrane. But let me tell you guys, that's not membrane, that's bone. You can actually see, and you'll see in some later slides, that almost a herringbone effect on the bone, where the ossix has actually, is osteogenic in itself, it's ossified, hence the name ossix. And it's really quite impressive. You think you could pick off that membrane with a sharp instrument. Let me tell you, you can't. It's solid. And then we place our implants. And I like this case to show, because then we're going to take some autogenous bone from our drill shavings. Can you see the bone isn't particularly thick here, because whilst our crestal bone was adequate, it wasn't overly thick, and we want it to be thicker. So whilst we've regenerated bone up here and up here, we want to use simple GBR techniques. And so we're going to use autogenous bone chips. And this is Ossix Volumax, which I'll show you a little bit more about later. It's basically a regenerative matrix. It's not simply a membrane. It's a very interesting product, and I use a lot of this stuff. So here, these are merely bone chips from the drill flutes, and then we've shaped some Volumax, and it's just literally providing volume. And then we close over again, and we'll wait here about 3 months or so, and then we re-enter, healing abutments, and restore. And these weren't my restorations. So let's mention a little bit of the handling of the membrane. Here we have a sizable defect, admittedly a class, well, it's a 3 or a 4 wall defect. So for the more savvy of you, you'll say, well, you could pack pretty much anything into that and bone will regenerate. And you're probably right, it would. So we actually, in this case, used a little bit of bone, autogenous bone from Safe Scraper and allograft once again. And I've also mixed with some xenograft because I'm sort of playing around with this stuff at times and seeing what gives me the best results. But the point on, and really the reason for the slide is, look what we've done with the OS6 Plus. We haven't really layered it, we've overlapped it. Problem, the handling difficulty with OS6 Plus is if you, say, cut it into a sort of big sort of shape, as you say would native collagen, when you place it into the defect and tuck it under the palatal, the edges on the sides will want to keep flicking up. And then when you try and close the flap, it catches the edges, it pulls the membrane out of the way. So the secret, and we'll show you this in the workshops if any of you ever come on them, we actually use it in smaller pieces, but overlap it so we can kind of go around the curve of our edge. And you'll see me do this a lot in these coming slides. Another case here where we, again, a big defect. I mean, this is very, very thin bone. It was a huge cyst under here that we cleaned out, and our plan was to place implants. And when we got in there, we realized that we couldn't, so we just grafted it. And then this is a mixture of autogenous and corticocancellous allograft. And here we go with our cross-linked collagen membrane. This is at surgery. This is at uncovering. And because we had a little bit overlapped here, we actually, this was loose membrane, which we just cleaned away, and it left us this. That, let me tell you, was solid bone. And you can again see, if I was able to blow this up, I can't, this herringbone effect from the membrane, where the membrane has actually ossified. It's taken several months to do it. You've got to allow time for this to happen. And as you can see, that's us having placed one implant. You can do this in socket grafting. So we've got a failing lateral incisor. And by the time we've removed it, we've got a complete blowout of the buccal plate. Sometimes you might elect to place an implant and graft. In this case, we didn't. Just didn't fancy it. There just wasn't enough bone from my liking. So we grafted. And this was a mixture of allograft and bovine bone mineral. We didn't want to go to a secondary site to collect autogenous, and we wanted to keep the sort of surgery quite minimal. So we didn't use autogenous in this case. But in a sort of 3-wall defect, you probably would get away with that. And then we used our OS6 Plus, as you can see, overlapping to allow for handling ease. And then we close up. And then we re-enter. Loose bit of membrane, which is fine, that's okay. Underneath, that's something that was membrane, but is now bone. Again, you can see this herringbone effect where the membrane is ossified. This is a consistent thing across all the cases. And that's actually where I've removed these sort of loose bits of membrane, and they just peel away, they're soft, they're membrane. But this is the stuff underneath that's actually calcified. And then that's at the beginning, that's at uncovering, and then the implant goes in with a healing abutment and then a restoration. Before treatment, after treatment. Pretty nice results. This was the case that changed everything for me. This really opened my eyes, because ignore these 2 slides here for a minute. This is what we had. And these were some sort of pretty ropey infected lower incisors. And one of the standard ways I'll treat these is I will, I'm kind of known as Mr. Immediate in some circles. I would remove these teeth gently. I'd place 2 implants. I'd graft. I would attach abutments. And then using a prefabricated 4-unit bridge, I would attach a bridge onto them as an immediate. That was my plan. I had the bridge made. I had the abutments ready to go. I basically flapped it, and I looked at the destruction of this alveolar bone. By the time I'd removed the 4 incisors, this is what I was left with. So all of a sudden, this immediate case was not an immediate case. This was a rethink. And this was about 4 years ago. This is really when I came back to OS6 Plus. And I had some, because it wasn't a planned procedure. I hadn't really, if you like, consented the patient to go back to his ramus and harvest some trifine cores and use autogenous bone. Today, I absolutely would, but I merely used corticocancellous allograft and OS6 Plus membrane. You'll have to trust me on this, because this was an unplanned procedure. All of a sudden, I was in not quite panic mode, but I was in thinking on my feet mode, and I didn't take any photographs of the actual surgery after that. Suffice to say, I showed me with the membrane in position, but I filled that defect up with my graft material. That's the membrane cut. And then about 6 months later, I saw that, and it felt firm. All of a sudden, I'm getting quite excited, because a case where I thought there was absolutely no hope, now there's a glimmer of hope. What is interesting about this is that, again, you'll have to trust me on this because I forgot to take photographs, is that we had a dehiscence of the crestal part of the wound that was there for about 6 to 8 weeks after the surgery. I saw him every week. And every time I saw him, I had to close my eyes because all I could see in this area was exposed membrane. And I could poke at it with a probe and it was soft, and I could still feel there was bone mineral underneath, but I thought this is certain to fail. But what happened, and this is the beauty of the ribose coating, the glide matrix technology, is if you do have a dehiscence and a membrane exposure, it will granulate over and it will heal. It will not do as, let's say, PTFE will do and get infected, and you are toast if that's the case. And PTFE will do that 100% of the time. This, you can get away with a dehiscence. I wouldn't say it's a reason to not manage your flaps well, but if it happens, as long as you can coach the patient to keep it clean with cotton buds and chlorhexidine, you're probably going to be okay. So how did this look when we uncovered and re-entered? Well, look at that. It was quite remarkable. That's the herringbone effect of the membrane, the calcified or ossified membrane. This is a trifine core, because all of a sudden I'm now saying, heck, and that was right in the middle of the teeth. There was no bone there. And I wanted to get histology of this, which I've done on several cases since. I'll show you the histology. I wanted to see what this actually was. We placed our 2 implants. You can see my trifine core there. I actually put some more graft material to further thicken it and another membrane. And it looks great. I should actually show you I should put the clinical photos in, I've forgotten, sorry. But we got a 4-unit bridge there, 4 years later, looks brand new. So let's have a look at the histology of that sample we took. I won't go through the details, time doesn't allow me to go through that. Suffice to say that we have numerous biomaterial blocks. So we've got residual biomaterial, residual allograft, surrounded by new bone tissue, which is stained in violet. And we have medullary spaces characterized by blood vessels. So we've got angiogenesis going on in there. This is at 7 months, I think. And we got numerous osteoclasts, which are basically the red asterisks, indicated we've got bone turnover. This is remodeling at the time we took the sample. And this was very exciting for me. And we blow up the samples even more. We've got new bone. Another case. This was a failed implant. This was an implant done in Slovakia or Slovenia, can't actually remember, 10 years before. Patient had multiple implants done there and he came in to see me about 3 years ago, 3.5 years ago. He said, my tooth is loose, my implant's loose. I literally pulled it out with my finger. We've done a lot of work on this chap. We replaced other implants. You might say, well, what was he doing getting this done in Slovenia 10 years ago? You know, he was very open with me about it. He said he knew what he was doing back then. It's all he could do, all he could afford. And he got 10 years out of it. And he was happy with that. He said to me, now my circumstances have changed, I want to do it better. So we've basically redone a lot of his work. And this is one of the cases. So we can see we've got a through and through defect, buccal, palatal, and vertical. Horrible for an upper central. So what do? We clean out. Look at this. Vertical, through and through, buccal and palatal. So we use some tenting screws. We use autogenous bone from a secondary site, 60-40, mixed with corticocancellous allograft. Ossix Plus, not layered, overlapped to go around that curvature of the graft to create the space. Close up. 8 months later, tenting screws sitting flush with the bone, all this bone is regenerated. Now, I'm sorry, guys, you will not be able to do that with a block, predictably. You might get lucky once or twice. I'm seeing this consistently. And we go on and place our implant. Subsequently, another tooth failed. This one, this lateral incisor failed. So at the same time, we'd taken that out and we went to place an implant there. I've done some further GBR on the grafted site with the implant. I've done another GBR procedure with some more autogenous and allograft and more Ossix Plus. And then we did the histology. I took the histology from this site up there. And we're going to see something very similar. In fact, I've got a summary of the histological samples, so I'm going to scant over this because I've got a complete summary of those two cases and this final case. And again, this is another case of a failed tooth, not a failed implant. By the time we've removed it, let it heal, we've got in a high smile line young female, through and through defect. And we took our graft material, which you'll all know by now what it is, and we use Ossix Plus in a overlapping, not layering technique. And then we look at this, we re-enter. I mean, even before we re-enter, I didn't even need to take a CT scan here to know that is bone. That tissue looks amazing compared to the pre-op. So something good has happened here. And then when we uncover it, look at that. That's just bone. That's normal bone. You wouldn't see that with a block graft. You'd see the block. It might be integrated and attached. It probably won't have much of a blood supply, but this is living, breathing, bleeding bone. Impressive stuff. Place our implant, took our sample for histology, and then this is some Ossix Volumax with some actual xenograft, because now we're just interested in filler and space maintenance. And we took the histology, and the histology was done by a professor I work with, a pathologist in Italy. And we're about to publish this paper, hopefully. We got interrupted by COVID, but here's the summary of those three cases. And we've got other cases now where we're adding into the data sample. And really what I want to focus on is lamellar bone, woven bone, osteoid matrix. This is new bone. And lamellar, because these cores I took were from areas where there was no bone. So there was no native bone in these cores. We've got 15% lamellar bone, let's call it 11.5% woven bone, and 11% osteoid matrix. So this is just bone that's turning over into something. And if we add it, 15, 11, 26, 37% new bone, let me tell you, is outstanding, because we would regard the histology of a grafted site as being good if we have 25% new bone, 25% residual biomaterial, and 50% connective tissue, which is the medullary spaces. We're doing better than that here. And that's interesting to me. So that's dealing with some big sort of defects. We're going to go and look here at a few.
Sorry, just before you go on to this next section, there's a couple of questions here. So first one is, what about placing Ossix bone into the socket extraction?
Coming to that.
And then what size of Ossix Plus do you regularly use?
Oh, that's a good question, because it comes in 3 sizes. So it depends on how much surgery you actually do, because these Ossix Plus it's not an expensive product, but it's not a cheap product by any stretch. So my advice is have a few of each size in stock, because The largest size is huge, and that's really for the very, very big defects. The small size is ideal for a single tooth site. So I would say get a range, and once you've used it a few times, you'll get, like anything else, you'll get a feel for what size you need to open. It's a bit like BIOS. Do I need 0.25 or do I need 0.5 cc's? It's a bit like that. The ossix bone question, I've got a little bit right at the end on ossix bone. So yes, it's a good indication for it, and I'll show you. Does that answer the questions?
Yeah.
Good.
Yeah.
So I'm going to show a case where, this is how I used to see things all the time. And this is simple contour augmentation, just using a xenograft and collagen mix. Okay, it's like a sponge. And here we have a really reasonable width, a little bit of thinning. So once we place our implant, we kind of want to fill that out a little bit. All you guys at TENS probably very excited to see a profile implant being used, and I use them a lot. I think it's a great implant, which we put a healing abutment on. And then this is our it's a classic xenograft collagen mix. If you really want to know, it's BIOS collagen. And it looks pretty good. And when we place it and suture it, it looks pretty good. By the time we get to the final restoration, we've lost some of that contour. And that's not really why I use this stuff. I wanted that contour back. And I see that fairly often with this product. I use this product a lot, but maybe not in this situation. What am I going to use now? I'm going to use Ossix Volumax. And what is Ossix Volumax? Well, it's basically a regenerative matrix. It's a sort of a morph between a membrane and a collagen membrane, which is cross-linked also, an actual sort of graft material that there's no mineral in there. But it's ideal for covering you see me doing it for contour augmentation in some of the slides before. I'll often cover a few exposed threads with some autogenous bone from drill flutes, then pop some Ossix Volumax over the top. Does the job very nicely. So here's an example, placed implant. I've got a little video which I couldn't upload here, but just to show the handling of it. But we create a little pocket and we tuck this stuff. You can fold it. You can fold it in 2 or 3 to create extra thickness, and then close it over. And then look at the difference by the time you get to the restoration. Crown's just been fitted, hence the blanching, but we've retained the contour, very much so. Handling of this is you want to create too big a pocket, because this ends up, when it gets wet with blood or moisture, it ends up like a little bit of jelly, and it won't stay there. Sometimes it'll disappear up into the sulcus, which isn't an issue, but it's not where you want it. And I'm going to show you a case here. Well, not this one, I think the next one, where we have attached it to the healing abutment. But here we go. These are just straightforward cases. It's straightforward day-to-day dentistry, where we place our implant, place a healing abutment, and this is the size. This is 10 by 40, because Ossix Volumax comes in all different sizes. This is a very neat one. I use, like for last patient tonight, I use this exact same piece of Volumax, and I folded it up into 3 and tucked it into the buccal pocket. And we've retained, look at this, we've retained all that volume. Very impressive. Here's what I was going to talk about. Upper lateral incisor, bit of a dehiscence stroke fenestration defect. Implant goes in. We take, I think I used a little bit of autogenous bone, and then I took some Volumax and I punched a little hole into it and used that to anchor the membrane or the Volumax rather, and stop it sliding up apically. Very useful. Now, there's normally a YouTube video goes here, but I'm not allowed to use this on webinar broadcast because of YouTube copyright. Suffice to say, the actual video is of a professional football match that took place in Scotland a few years ago, and it showed a head collision between 2 players off the same side, and the damage was that. And he came in, and this is when I first saw him. Teeth were avulsed, lateral incisor was halved just about, and that's the first I saw of him. I said, wow. He said, do you want to see how it happened? I said, oh, okay. And because the football match had been televised, he showed me the footage, and actually he's given me permission. I've showed the video many times at different lecture theatres around the world. And it's quite interesting because not many people are able to show how trauma actually happened. And this is one where I can. I do have the footage. Suffice to say, we've lost 3 teeth. We're going to replace them with 3 implants. And the bone is pretty good, as you'll see, because we didn't wait too long. We re-entered following the trauma at about 6 weeks. And yes, we've got a bit of dehiscence here. We've got a bit of a crestal defect, but I'm not too concerned about that. You can pack anything in that defect and it will be okay. But bearing in mind the guy's 23, 24, I'm really looking for long-term tissue stability, even in the presence of good bone. Here, a bit of a defect here. So what do we use? We use some graft material and some autogenous, and then I just covered it with Ossix Volumax, 2 layers of it. And what did that allow us to do? Look at the thickness of the tissue. This is where we have the dehiscence. And 3 crowns. And it looks fantastic. In fact, it doesn't look so good now. Why is that? See this, we had a bit of a palatable part of the fracture. We did put a crown on that. And 2.5 years later, he developed a fistula here. And right now he's got a partial denture replacing that one. And we're going to put an implant in. Actually, he's in next week for his implant placement, for his 4th implant placement. Before the question comes in young adults in the anterior zone, I like to go for single tooth replacement. If there's 2 teeth missing, I'm using 2 implants. If there's 3 teeth missing, I'm using 3 implants. And in some cases, if there are 4 teeth missing, I'll use 4 implants if space permits me to do it. But very often when you're trying to replace 4 teeth, you actually can't get 4 implants in perfect position. So sometimes I will use 3 implants for 4 teeth. In young adults, this is my go-to because I think these are there for a long time. And patients like it because they're individual teeth, they can floss, they can clean them normally. And that's a really departure I've made in the last few years, where I probably would have done that if it was 4 teeth with 2 implants and a 4-unit bridge. Can we use this in the posterior mandible? Well, the simple answer is yes. Here we are, thin ridge. Obviously, so we've had some dental excitement here in the past. When we raise our flap, we've got defects, but this is all pretty thin. A couple of tenting screws. Because we're in the posterior mandible, go back, I just extended the flap all the way back, harvested 3 or 4 cores from the ramus, mixed it 60-40 with corticocancellous allograft, and you can see we really packed it around. And then we shaped, and this is the larger size of Ossix Plus, which we shaped, and then we've re-entered. This is now at about 8 months. We re-enter, cover the tenting screws are there. We've now got bone up to the top of the tenting screws. And look, this is something I mentioned earlier. Look, our best bone is right under the tenting screw. So don't be afraid to put 3, 4, 5 tenting screws. It'll only help you. And then we place 4 implants using a guide. You know what? The plan was to place 3 and have a 4-unit bridge. And I opened it up and I was so excited with the bone. I said to the patient, I said, I'm going to put a 4th implant in to give you 4 individual teeth, and I'm not going to charge you because it just looked right. And we did, and we fitted the final one just not that long ago because we got delayed by COVID in that case. Here's another case. You can see, get an idea of the bone missing here. Yeah, it's going to be a very hard implant to place in the perfect position and not have the majority of implant outside of the bone. So 1 tenting screw. Well, here we go. This is my usual mix of bone. I won't even say what it is. You know what it is. Ossix Plus. I think actually that's Ossix Volumax. Oh no, it's Ossix Plus. And we had 2 laterals exactly the same. And they are Rochette bridges as provisionals. Re-enter. Look, bone covering the tenting screw. Bone up to the tenting screw. Implants go in. very, very, very impressive bone regeneration. Here's another one, and this is, I'm showing this case to highlight something that you're going to come across. Sort of a big buckle defect here. And again, tenting screws, my mix. So we harvested from the ramus again, mix it with our graft material, and you can see us just packing the bone, building it up around the tenting screws. Ossix plus overlapped to make it. You couldn't do that in one piece of membrane because you'd never get the flap closed without the membrane popping up and losing a bit of graft material. It just gets very messy. And then we close up. And what happens a lot when you're really building out buckle here, you'll end up almost sewing the cheek to the ridge. So when you go to place implants in the perfect position, you're going to be in non-keratinized tissue. So very, very often in these sorts of cases, the next stage is a free gingival graft to expand that zone of connective tissue because of the degree of advancement you've had to do. And that's it after that particular graft. That's it at about 3 months. And then in her case, she's got a high lip line, gummy smile. Great patient this is. Allow us to do anything we like on her within reason. She wanted that sorted, so we've done that at the same time. And just after about 2 weeks after I did the crown lengthening, I went back and placed the implants. So we've got really, really nice ridge tissue here, no non-keratinized tissue. There we are. Now, interestingly enough, I had if you remember, I had 3 tenting screws. This one is completely covered with bone. I've actually left that in because to remove it, I'd have to remove this bone, which means I lose a little bit of volume, lose a bit of shape to the tissue because one implant's gone there, the other implant's gone there, and I managed to prepare those implant sites perfectly without needing to worry about the tenting screw that's sitting under there. So that's still there. That will remain there. So, sorry,
just before you go on to the next part, Tom has asked, I've used Ossix Volumax, but have had a dehiscence, even though my flap was closed with no tension, and I've lost the volume to expose the implant. What went wrong?
I don't know. I'd need to see the pictures. It could be, did he say the flap dehisced, the flap broke down?
Yeah, even though my flap was closed, yeah.
Yeah, so it was probably closed with maybe too much tension, didn't remain closed.
Tom, that could be something that maybe you could send some pictures to.
Yeah.
Steve, and maybe discuss, and we can try and find what's gone wrong and how we can support you on that one. Another question, what tenting screw system do you use?
Good question. I buy my tenting screws from Salvin. They are an American-based company. So, well, historically, anytime I was over there and there was a trade exhibition at the meeting I was at, I would pop onto the Salvin stand and I'll stock up on tenting screws. I use some of their membrane tacks as well for other, I do other types of particulate grafts as well. I do a lot of what's called the sausage technique, which is also good. So I use a lot of membrane tacks and stuff like that. But Salvin is where I get my tenting screws. But there are a number of companies that use tenting screws.
Thank you. And then, so Tom is going to try and get some photographs across. He's asking, what about post-ops? What's your regime?
For these graft cases, I will use antibiotics, anti-inflammatories. Simple stuff, really. Nothing dramatic.
Finally, when you remove tenting screws, do you have to fill the holes they leave?
No, it's a bit like if you've done block grafts in the past and you've re-entered and you've removed the fixation screw. You know, if you've got good bone there, it'll usually, you'll see bleeding coming through it. You just, yeah, it's fine. You don't need to fill it with anything.
That's us. Thanks, Stephen.
So I'm going to actually skip a bit here because I'm not going to really talk about socket grafts. It's not really for today. Suffice to say that, you know, I'm going to often use Ossix Plus and allograft in sockets like this, and they regenerate very, very nicely. a study that we're in the process of trying to get published, where we looked at grafted sites and implant stability, which is a particular interest of mine. Showed that we had, pretty much as similar, same success rates with implants placed into socket grafts as into native bone healed sites, and in terms of implant stability, insertion torque, ISQs, all very, very similar. And this was a study of, these are my co-collaborators. But anyway, this shouldn't really be in this presentation. But hopefully that'll be published later this year. So finally, we're going to look at ossix bone, which I've sort of started to dabble in a little bit more. A lot of these slides aren't my slides, so but they show some very interesting results. Again, it's using the Glymatrix technology. These are sort of sugar cross-linked collagen sort of sponges, if you like, come in 3 different sizes. And they really are quite neat in sockets. What I would say with sockets is that if you're going to place ossix bone into a socket, it's the sort of thing, you've almost got to take the tooth out, you've got to offer this sponge up to the socket, let it soak up the blood, and then slowly advance into the socket. Otherwise, it'll sort of crumble away. And I would then use a little bit of ossix plus membrane over the top, just to basically seal it over. Remember what I said about ossix plus. If it dehisces during healing, it doesn't seem to be a problem. It will granulate over. Well, this is the complete dehiscence, if you like. If you put ossix plus over a socket, then there is no tissue covering it, and it seems to granulate and heal very, very nicely. This is slides from a colleague of mine called Matt Fine, and you can see just a huge sort of defect in the mandible, where if you just took the tooth out and left it and then went back, you might find you've got issues with ID canals and stuff like that. But at the time of extraction and curettage, using ossix bone and suturing, managed to achieve a very nice infill, such that 8 months later, we have this, and we have then a reasonable site, which you can then just manage in conventional ways, implants, bit of GBR if you want, like this. And as you can see, he went back in with some ossix Volumax. So you can use these materials in combination at different stages of the treatment process. And then this has been, I've started to use this on a lot of internal sinus lifts, where instead of using other graft materials, prepare my osteotomy, and then just very carefully offer this sponge of ossix bone into the site, and then gently using our osteotome elevate the sinus lining. And it's a great little product for that. And my good friend Barry Levin from Philadelphia has just published a very nice paper showing a case series of 20 or 30 cases of internal sinus grafts with ossix bone. I think that's gone into JPRD, one of the recent editions. In fact, that was a preview of it that he published in Compendium, case series of 28 consecutive patients. Very, very nice. And obviously with these things, you're not going to get histology because you're not going to re-enter and take cores. So it's an assumption from radiographic appearance that what we have is osseous in nature, I think is the best way of talking about it or describing it. So in conclusion, really, the last sort of hour or so, you've seen the importance of assessing the shape and size of the defect, and then choosing the technique and choosing your materials. There's a whole range of stuff out there, and I will often have a chat with the patient, and they'll ask me, well, you say to me, I'm going to need some bone augmentation or some bone grafting. You say you're talking about human-derived and animal-derived products. What are you going to use? And often I'll say, well, I don't know yet, but I'm going to use the product and the technique that's going to give you the best result. It's not how I'm feeling on that particular day. So that's why we have a range of stuff that we can use. But you do need to understand the value of these materials and how they will work. And it's really an area that's still changing and developing. Good industry partners, because there's a lot of advice that they can give you. You have to be critical, however, in evaluating yourself, the techniques and materials and the evidence behind them. It's so important. And of course, it's a given. And I said this right at the beginning, you know, getting implants in the perfect position is an absolute given, because these materials will not dig you out of holes where you haven't got the surgery right, where the implants aren't in the right position. It's the surgical skill and ability to cover a range of different situations. There is no substitute for excellent basic surgical skills. It's not all about the materials. It's probably mostly about the surgeon, and then the materials are there to help you. And I think that is it. Thank you very, very much. I'm sure there are, well, I would imagine there's lots and lots of questions. Just to say that I'm actually looking at these bottom two pictures with a lot of excitement because Queen Nicola has finally let us free as of Friday afternoon. So Friday afternoon, I'm going to be down here at Turnberry playing golf, which I haven't been able to get to since November. So
is your tea time all set then? Have you got your appointment booked and ready to go?
I'm playing Friday, Saturday, Sunday.
Good. Make up for lost time. Well, listen.
And one day I might be here as well.
Stephen, I'm going to ask everyone to put any questions that they've got for the end into the chat box just now. I'm going to quickly share my presentation. I've got some slides on OSIX that I wanted to share, and then we'll come to the questions at the end, if that's okay.
Sure.
So I will quickly just share. So again, thank you so much for that presentation. That was really great, really insightful. I'm just going to very briefly run through a couple of slides. So again, you covered all of this. What's the most important thing when you're looking at GBR materials? So stability of the graft, the final bone quality that you're going to get from the graft, the handling characteristics, and I thought it was excellent, the hints and tips that you've gave on OSIX this evening. Patient choice, and that's becoming more and more important. I'm getting calls regularly from dentists asking for alternative choices from patients if they are vegan or, you know, maybe for certain religious reasons. So it's just having a lot of different choices out there. And evidence, you know, you mentioned it yourself. For us, you know, something that's got a lot of evidence, and that's really important in a lot of the products that Dentsply Sirona have in their portfolio. So according to a study published in the Journal of Dental Research in September 2015, that analysed data from 40 clinical studies evaluating bone augmentation, the conclusion of that overall study was that the intervention combining bone replacement grafts with barrier membranes was associated with superior outcomes. So really and truly, you've mentioned it through the whole stage, using a membrane is really important, and OSIX Plus has obviously gave you some really great results in these cases. So a bone graft, the successful GTR is a bone graft that maintains volume and provides true bone with no remnants. It provides the membrane provides a long enough barrier function, so over 3 months, ensuring soft tissue doesn't penetrate the regeneration site. It's highly biocompatible materials, safe and accepted by the patients as its own, so it doesn't reject the graft. Highly tolerant of complication, patient and non-compliance, and materials that are easy to use both by specialists and general dentists. So again, you mentioned it all starts with this Glide Matrix technology, and when I joined Dentsply and OSIX came into this portfolio, I was really excited about this technology. It's a collagen cross-linked technology that mimics the natural collagen cycle in our body by using sugars to organise and link collagen molecules, producing a collagen matrix. The fact that we use a sugar-linked collagen means that there's no inflammation, as there would be with some of the other chemical-linked collagens. The matrix is resilient enough to withstand the harsh environment of the mouth, while intelligent enough to foster bone growth. So I'm going to quickly share a video just from Datum Dental about what the Glymatrix technology is, but they're the best people in the world to explain it to you.
Nature is our inspiration. Excellence is our passion. Everything we do is designed to give nature its best chance. Our patented Glymatrix technology mimics the natural collagen cycle in our body. Glymatrix is what powers OSSIX products for guided bone and tissue regeneration. Glymatrix is clinically proven, covered by over 100 scientific publications, with extensive clinical experience worldwide, spanning decades in hundreds of thousands of procedures. Let's take a closer look. First, natural type 1 porcine collagen is extracted. Then molecular triple helix collagen is released and extracted, then purified. Next, during enzymatic treatment, immunogenic telopeptides are eliminated. During fibrillation, thin fibrils bundle together to form collagen fibers. Finally, Glymatrix utilizes naturally occurring non-toxic sugar as the cross-linking agent. The polymeric collagen is then reconstituted to serve as the core for OSSIX regenerative solutions. Glymatrix is fully bioprogrammable for specifically engineering long-lasting biomaterials with enhanced stability and specialized properties needed for OSSIX products. Meet our solutions for guided bone and tissue regeneration: OSSIX Plus, OSSIX Volumax, and OSSIX Bone, the newest member of our family. Glymatrix powers OSSIX Plus, the only ossifying membrane resistant to degradation when exposed, and maintains barrier function for 6 months. OSSIX Volumax is a unique volumizing, ossifying collagen scaffold. OSSIX Bone, ossifying collagen sponge, promotes true bone without remnants. OSSIX regenerative solutions are used in a wide variety of indications, from routine procedures to challenging cases. Everything we do is designed to give nature its best chance. OSSIX brand by Datum Dental, redefining regeneration.
So the OSSIX solutions, as Stephen has spent a long time going over this evening, we have the OSSIX Plus, which is the only ossifying membrane, the OSSIX Volumax, which is an ossifying scaffold, and the OSSIX Bone. We've also recently just relaunched our membranes, our Symbios Bone Shield, formerly known as Freos Bone Shield. They're non-animal, non-human in origin, and they're used to treat well-informed patient groups. Symbios Bone Shield has been around for a long time. It's got over 20 years of data. It's the ideal choice of people who want to offer a non-animal and non-human derived membrane, and it's got with 20 years of clinical experience. So very, very briefly, just to wrap up before we get on to questions with Stephen, Dentsply Sirona, why partner with us? Well, we're the largest global infrastructure in dentistry. We're committed to leading education and innovation. We're passionate about, educating dentists, their teams, and their patients, and provide solutions to improve efficiency and advance patient care. We're seen all over the world. And what does that do for us? Well, that means that we can bring technologies and solutions like Datum Dental from Israel and share it with a global marketplace. Myself and my colleagues are here and committed to partner with you to bring the best outcomes for your patients. We'll deliver innovative dental product solutions to improve oral health worldwide. The future of dentistry is digital. We know that you're ready to connect. Treat your patients with better, safer and faster digital solutions, technologies and equipment from Dentsply Sonona. We have a workflow for everything that your patient will need. Let us be your partner in your digital journey. So please get in touch if you would like to hear more about our Osix portfolio. As I said, myself and my colleagues are here to support you with that. But I think more importantly, I'm going to hand back over to our keynote speaker of the evening, and let's get some of these questions.
Can I share a little anecdote that just occurred to me? I meant to mention it during the presentation, and it's a COVID-related anecdote just to show the power of these products. So what I didn't show today was that any one of the numerous cases that I do day to day, every single day in my office, where we'll place an implant and do a simple GBR with some allograft and Osix Plus, just a simple buccal GBR. And we normally will re-enter at about sort of anything between 8 and 12 or 16 weeks, 2, 3, 4 months, not very long. And what we find is we find the implant quite easily, put healing abutment on, and off we go. So we did lots and lots of these in January, February, March last year. And then, of course, lockdown came. We were shut for 3 months. So when we reopened in June, we revisited and re-entered a lot of these implant placements we placed not 2, 3 months before, but 5, 6, 7, 8 months before. And my nursing team will back this up, because without one exception, every single case, when we re-entered, we couldn't find the implant. It was buried under bone, and we had to drill away bone to get it, right? And it really suggests, it begs a question actually. It tells us one thing: we've grown bone vertically on top of the implant, which is where we didn't really want it, because the implant's in the perfect position anyway. So that tells me that where we really wanted it, which was buccally, it's got to be there. It has to be bone. And this stuff is bone. Let me tell you, it's a high-speed drill to remove it. It begs the question, though, should we actually be leaving our implants 4, 5, 6, 7 months and not 2 or 3 months? I don't think our patient base would stand that. Maybe our bone products need a little bit longer to mature. Doesn't seem to be an issue, but it was a purely anecdotal finding that we observed during lockdown, and it was very interesting. And the combination of materials was consistently that membrane and an allograft. Very, very interesting. It was fascinating.
Again, I think that would be quite a nice debate again at a later time. But that's great. So I have got some questions here. Going back, so what about chlorohex? Finding evidence to say that it kills fibroblasts?
Yeah, I mean, there's lots of evidence about that. And listen, we can debate it. In my patient base, one thing I tell them not to do when we've done a complex flap procedure is to avoid it with a traumatic toothbrush. So they're going to have to clean it, and they can't clean it manually. So what are they going to use? Well, I think the advantages of using chlorhexidine 0.5% as what we used to call dental domestos outweigh the potential fibroblast issue. Suffice to say, every single surgery I do, and we do lots, they get chlorhexidine to use afterwards. I've not really seen a problem.
Okay, super. So next one, if you fold Osix Volumax, does it matter if the folded side is apical or crestal?
Yeah, well, yes and no. Okay, so the no is it doesn't matter, all right? But the yes is if you, and I'm going to use an envelope here, all right? If this is your Osix Volumax, you Hello Fresh, you know? If this is Osix Volumax and you're going to fold it like that, and this is my implant, and that's the implant platform, okay? If you position it like that, then this bit can unfold itself a bit, and you lose the volume, okay? Whereas if you just do that and have the fold at the top, it doesn't matter what happens down there, you've retained your volume up here. So it does matter, but nothing biological. It's just a practical handling exercise, I think.
Perfect. That was good. Good use of props there, Stephen. What is your preferred sutures?
This is a lot. Shall I tell you what I carry? And then I'll try and tell you what I use in certain situations. So my workhorse suture is probably Proline 5.0 and 6.0, depending on tissue thickness. Thinner the tissue, I'm moving towards 6.0. I will use quite a lot of PTFE, cycloplast, for big, long, big flaps, big crestal incisions. I'll do a continuous interlocking suture with that. It's very easy, very nice, and very easy, nice to handle. I use quite a bit of glycolon, which is a resorbable monofilament. So if I'm doing a big graft and I want 2-layered closure, so if I'm doing, and I do quite a few Istan urban sausage techniques, then I will do a 2-layer closure with some mattress sutures at a deeper level. So I'll need a resorbable suture in there because I'm going to find it difficult to get at it to remove. So I'll use glycolon, beautiful suture, 5.0, 6.0, but they're not cheap. And last on the list, Vicorapide. We use it. So I'll use Vicorapide if I'm closing a secondary site in the ramus where I've harvested bone. It's an awkward site to get to remove, so I want something resorbable. I'm not too bothered about the quality of tissue after healing down there. It will heal. But where I'm working in the aesthetic zone where I want minimal scarring, minimal inflammation, I'm using a monofilament all the time.
Yeah. Grand. Next question, where do you get your allograft particles from?
Am I allowed to say? You used to work for them. I use a lot of Mineros, which is a BioHorizons product. Yeah. I use a lot of it. I mean, go through buckets full of it. And that's, the industry is polarized geographically, I find. So historically, Europe, UK has always been very much a Swiss-based arena. In other words, Geistlich, BIOS, BioGuide. And these materials are great, but they are limited. And there are better things around for certain situations, as I've tried to show you tonight. Living through that time, and I spend a lot of my professional life in North America, and even through all the days where we were going through lots and lots of BIOS and BioGuide, if you speak to my American colleagues, they were using a lot of materials. They used in fact, Geistlich didn't really have a foothold in North America, not until the last 10 years. They weren't a company there. Their products were sold by another company under license. So, Biogenics, can't remember who it was. Anyway, it doesn't matter. But what they would use mainly was allograft. So they would use Rocky Mountain, a lot of Puros, which is a Zimmer product. And they would not use much bovine at all, much xenograft. But then I think over time, and Southeast Asia was pretty much Geistlich orientated in that sense. But then over time, I think these worlds have merged together. There's a lot more bovine, a lot more xenograft being used in North America, and there's a hell of a lot more allograft being used in the UK and Europe. I think our eyes have been opened to the value of having different tools at your disposal. But if you want a general appraisal of the two materials, and this is very, very generalized, it's, if you want something non-resorbable, then you want xenograft because it'll stick around forever and won't really turn into bone very efficiently. But it'll act as a filler and a space maintainer very nicely. If you want something that's going to regenerate and turn into bone, then you want an allograft. Problem with an allograft is it resorbs quicker. So if you're going to use an allograft, you need a barrier membrane that's going to stick around for longer. So if you use an allograft with, say, a native collagen membrane that's disappeared at 6 to 8 weeks, you're going to risk your graft. Depending on the biology of the patient, you might get away with it. So if you're going to use an allograft, predominantly an allograft mixed with autogenous, which is also a fastly resorbing material, autogenous, then you want a barrier membrane that's going to stick around. And what do you want? You want PTFE, which stays there until you remove it, or in my world now on a daily basis, I use Osix Plus every single day in my office. There's not a day goes by where I don't open Osix Plus and Osix Volumax, which happens every day. So I'll use a lot of this stuff. I mentioned I do a lot of particulate grass using the Istvan urban sausage technique. And the principle behind that technique is it's xenograft mixed with autogenous and a native collagen membrane. Fully aware of the fact that your native collagen membrane has disappeared after several weeks. But what's happening is your xenograft is acting as your matrix to support your autogenous, and it has to be 50-50 at least, more like 60-40 autogenous to give you a chance. If you try and do, say, an Istvan urban sausage technique with just BioOS, it won't work. It just simply won't work. You'll re-enter and you'll either find a just mush of BioOS that'll just disappear up your aspirator. It certainly won't be bone. So you have to understand what you're using and why you're using it, how these materials perform. Because if you get those things mixed up, then it's, you will risk failure, and that's the problem. And these are patients; these are paying patients we're dealing with. So we don't really want to have to re-enter and redo procedures like that take the best part of a couple of hours.
Yeah, stressful. So, do you need primary closure with Osix Volumax?
Well, I use Osix Volumax a lot with one-stage surgeries where I'm placing an implant and a healing abutment. So by definition, there isn't primary closure. Yes, we're suturing the tissue around the healing abutment, so we're kind of covering the Osix Volumax, but by definition, that isn't primary closure. In any buried situation, you always want primary closure. Why would you not try and achieve it? It's going to give your chances of success. It's going to raise your chance of success. As I showed, the interesting case with Osix Plus, and I've seen this many, many times, is if you do have a breakdown of your wound, if it does dehiss, you'll probably still be okay. But I wouldn't, as I said to you at the end, don't substitute these materials for poor technique. Technique has to be good and right, and then these materials will work for you in most cases.
We've got quite a few people interested in the course, Stephen, so that's great. We'll get back to them once we've agreed dates and locations. Last question, I think, with Osix bone, should you use degranulation burrs before placing?
Before in a socket, I assume that's the question. Yeah. Well, not burrs. I actually very rarely put a burr inside a socket unless I'm placing an implant, which I do a lot. But I will use a Lucas curette, but I have a particular style of Lucas curette that has a serrated tip. And you can get these from Q3D, Salvin, most suppliers have them. So it's not just a spoon-shaped tip. It has, I haven't got a picture of one, but if someone wants to email me, I'll give them the product code from Q3D or Salvin. With a serrated tip, you can actually really scrape away the inside of the bone in that socket and degranulate. But what you're actually doing, you're removing remnants of periodontium and granulation tissue, infection, and often it's endodontic material removing as well. So yeah, but I won't use a burr. I'll use a hand instrument. But that's just style. That's just how I do it.
Perfect. Lots of people saying thanks very much as well. So I think that's us, Stephen. Thank you very much for your time. That was a really engaging question and answering session, everyone as well. So thanks very much for that. We will definitely get back to you once Stephen's agreed dates and areas on the course. And that'll be.
And I would say, if you, by all means, try Osix Plus, please don't get disheartened when you start fighting with it in your first few cases. You will, and there's a learning curve. If you want to wait until we've done some workshops and then I'll show you the tips and the tricks, you'll not have so many of these issues. But the reason I used it 20 plus years ago and stopped using it was handling. And And now, in those days it was OSIX. Now it's changed. It's a little bit more flexible in OSIX Plus, but it's still not easy to handle. But as you can see, there are ways of doing it, and there are ways of doing it predictably. And I can only show you this in a live patient situation or an animal model. But yeah, by all means try it, but don't get disheartened if you struggle a little bit at first. Feel free to email me. I'm sure the Dentsply team will give you my email address. It's not a problem. I'll try and help you through it if you have an issue.
Perfect. Well, thanks very much for that, Stephen. That's really kind of you. We've gone over. I appreciate you giving your time up for tonight. I appreciate everyone joining us this evening. It's been a really good evening, really great question and answering session. Please get in touch with us. There's a few of you that wanted to get in touch with Stephen with some pictures of things that have happened with graphs, if you're okay with that. Please get in touch with myself or directly with Stephen, or I can put you in touch. But yeah, that's us for the evening. Thank you very much, and I hope you enjoy the rest of your Tuesday night.